Part of our interest is thinking in terms of what happened in health reform, which obviously increased health insurance coverage a lot, but not necessarily, and statistics suggest that it helped improve access, though at the same time, what we gather from our prior study and other studies was, at the same time, just having an insurance card is not enough. There need to be places where you can get health care, and then in some cases there have been some issues in Massachusetts, and that there continue to be some people who are uninsured and sort of without access. And then also more recently what's been going on with the budget cuts. Would anyone like to start out and give us their thoughts?
People between 18 to 21 is the hardest. Them to get insurance because they think they're not going to get that sick. They think that they're not going to need it.
Right.
And a lot of what we see coming in, those are the most needy.
The rate of people insured rose dramatically, but that was because there was a huge effort, community effort, to educate people about it.
Sure.
And so we have an outreach network, NEON, that worked really hard to inform the population. So while there's still pockets of people not insured, I think you'll find from Jeff that a lot of our folks, especially women, are insured and visit. I think what's missing now is the gap we're trying to fill in transportation and also awareness. How does your lifestyle contribute to your health? And so everybody's got, mass health or some sort of coverage, but now how do you use that coverage and how do you make changes in your life so that you're not sick?
And 95 plus or better of the participants had no coverage, so we personally had to get in a representative to sign them up one by one with Mass Health. Many coming from formerly incarcerated young people.
Certainly one of the things when we were talking with people in focus groups yesterday was people would say, gee, sometimes you can't find a primary care doctor. Even if you do have a primary care doctor, it may take a really long time to get an appointment. But my impression was you were talking about something sort of even a little deeper than just that sort of thing.
Here in Massachusetts, in Springfield, for example, we don't have a needle access program.
Okay.
The legislature just recently made it so that it's not illegal to buy needles. It was up until illegal, but our city government won't allow us to do a needle exchange program. So we have multiple issues in terms of not just between intravenous users and intravenous users, but then where people are using. We have a daycare center, for example, in Main Street, and in order to make it safe, I had to put a rubber play floor on it, because otherwise, every day we'd have to go in there through the grass and try to find the needles, because that's where people are finding needles. So we have public issues around needle access, but yet we still haven't been able to shape policy enough to sort of come away from, well, then we'll just be encouraging drug. The idea that we have access to health now has been a big change. It has. I think it's been a very positive change. And more people go to the doctor than ever before. But I think if you visit Bay State, they would still tell you that there's a preponderance of people who use the emergency room as their primary care physicians, still today, even though. And part of that reason is if you go to the Brightwood Health Clinic, though whether Jeff will admit to it or not, there are times when people might have an 11 o'clock appointment and they will make sure that they bring their lunch because they'll be sitting there till 3 o'clock. And so there are barriers that keep people.
We certainly heard that, and not only for some of the health centers, but actually for the ER.
The ER, then you're forever there.
Environmental factors are huge, and I think, like Michael was sort of suggesting, I'm involved in a couple of efforts to go beyond the focus on individual behavioral change and think about the structural explanations for low health outcomes, like the highway, like the indoor air quality at some of the schools, like the bus depot on Main Street, like the proposed biomass plant in a majority-minority community that would have been burning construction and demolition waste. and several other factors. I think people are just, like Michael was saying, just starting to get a handle on the structural issues and the necessity to look at on the policy level to deal with individual health outcomes.
Traditionally, where uninsurance has had problems, particularly in a place like Massachusetts, is actually for people who are under poverty. In many cases, lots of them are able to get things like Medicaid. Mm-hmm. So there they have some, still have high uninsurance rates, but there was a fairly strong public cushion that existed beforehand. Where what happened was you go up above the poverty line, say 1 to 200 to 300% of poverty. That's where you find people who maybe traditionally don't have Medicaid, don't have mass health, but still aren't necessarily in the right sort of job that they have private insurance coverage.
Right, because what happens also is with the private insurance is the insurance keeps rising up, and the employee, we have to pay more because our employee cannot afford whatever is going on, and they give out all this stimulus money, and hopefully that will change with the new health. But something needs to be done because, especially on the small businesses and employees that are less than 100 employees, you get all your money. A lot of your money goes to supply the health for your employees, your portion. And we right now we're what 60-40, 60-40. So it's not. It's a balance that if the insurance keeps going up and up and up and up, pretty soon, you're gonna have an employer really. You're gonna be just paying a lot of money just for your insurance.
Well, employers
won't pay it. They just drop it.
No, they choose to pay the fine. My son's a waiter, works at a restaurant, and they don't offer health insurance.
How do we create more doctors that look like me, males and females? And that's the thing that I've been working with university. That university does, like the medical school. How do you get hospitals to open more doors for minorities to become administrators, to become doctors, to have all the different structures? And the thing is that you ask yourself the question. I used to have this question asked of me every time I tried to push for a minority person to go to the medical school, and the dean of the medical school will put it, say, well, Herbie, you want a qualified person. You want the best qualified person. When you're in that bed, you don't want to think that person just got there because somebody opened the door and certain things like that. And that's a psychological thing. I said, well, it don't make any difference. I had a guy that went to Harvard. He's not even want to deal with me. In Springfield, I've been told that there are jobs $65,000 or above, like in Bay State. But they cannot find people in Springfield. They go outside and get them. And so we're never going to change all the statistics that you have there. You're never going to change because they're going to continue recycling. You got to have to change that whole economic structure. Mm-hmm. And if those people go into the health and they know, we should not eat that kind of food, or we should not do this, or we should do exercise, and even for us in the leadership, we talk about it, but sometimes we work 16 or 17 hours a day, and we are the worst offender in taking care of ourselves, right, Michael?
Yeah, right, Herbie?
Guess you compare notes.
It's like it's kind of thing. Yeah. So I think that's the encouraging thing I think is that I think lately a group of young people that they have gone to college, that have come out, that they are looking at a different perspective, and they are willing to set up a foundation. So I think that how many jobs are going to be created should be on any report.
Community health centers probably come about as close as any place in the healthcare system of trying to have a diverse workforce. Have been important in sort of helping to continue to open up care. Now, there's still problems. I mean, yesterday when we were talking to focus groups, there's no question that lots of people were saying, it may be that there's, more health centers, places like Brightwood or Caring or whoever, they still can't get a doctor's appointment. So, it can make a dent. It's not necessarily a silver bullet.